me here and for letting me answering the question whether there is still a need for a new strategy in H. pylori eradication. So now I'm coming back to the clinical ground, back from the science as we heard, and first of all, when we want to talk about H. pylori eradication, we have to think, despite the fact that we got many advances in and the relevant data today, still we have to admit that treatment of H. pylori infection is nowadays a huge problem in many clinical settings. And why is that so? We have seen that the prevalence rates are declining, so in developed countries there must be any problem when we think about it, but we think we have seen that the eradication rates are increasing due to the prevalence of resistance traits, because the prevalence of resistance traits now are really, as we will see on the other slides, increasing. And the eradication rates are nowadays at the lowest level we have seen in all the past decades. And therefore, we think we are managing a huge problem because they are further likely to decline as the air resistance becomes more prevalent. And why is that so? First of all, the antimicrobials that we use for H. pylori treatment, they were originally designed for other infections, because they were not specifically designed to achieve high concentrations in gastric mucus. And therefore, we clinicians have to use a variety of methods in order to achieve a successful eradication. We combine antimicrobial treatment with PPIs, we use combination, and all of this we do in order to increase the likelihood of success of our treatment. And still, despite this fact, we see three major problems in antimicrobial treatment regimen. And as you can see, this is a quite old paper I'm presenting, but still, despite the fact that it was published in the late 80s, nothing has changed. Because still we have to face the problem with adherence, with the treatment regimen, with intolerable side effects that can lead to premature discontinuation of therapy and also to the development of resistant strains. And still, despite the fact that we have now, for example, many treatment regimens as the quadruple sequential therapies, but still these regimens are very complex. And in order to maintain sufficient concentrations of antimicrobials in the gastric mucus, we have to think of many of these factors. We have to think of dosing regimens, gastric pH, emptying, and so on. And to list all these factors, I have shown you in this slide all the complexity of this problem. And therefore, the European Helicobacter pylori study group invites from 1996 the group of experts that gathers together in order to get us clinicians recommendations for the clinical practice. And this is the latest recommendation that was published this year in GATT. And we have seen all the summary of treatment strategies that are mainly based on the prevalence rates due to the clarithromycin. Because in regions with low clarithromycin prevalence, we can use these regimens, and we use other regimens in areas with high prevalence. The Americans, they got their own guidelines. They are not so oriented due to the resistance rate, but we can see that they are mainly of longer duration than the European guidelines are. And these are the guidelines shown from the American Gastroenterological Association. But when we go through all these guidelines we know and we are aware of, we see that there are three key agents that are used to treat H. pylori, and that is amoxicillin, clarithromycin, and metronidazole. And most of the successful treatment regimens for H. pylori contains one of these agents, or even more of them. But the antimicrobial resistance, as I've been talking about, is a major cause of treatment failure and is responsible for the decline rates of eradication of H. pylori seen in many countries. Therefore, the factor number one that can affect the successful eradication is resistant to antimicrobial agent. And this is also shown in this slide, because when we want to treat H. pylori, we have to have pH between range 6, and 7, because this is where the active replication of H. pylori takes place, and this is where the organism is only susceptible to be killed by antibiotics. And this is a slide where is shown the huge percentage of resistance rates. As we can see, for clarithromycin, these rates are from 12% up to nearly 85%. And for metronidazole, this goes from 13% up to 100%. So really, this is a huge problem nowadays, and we should face with it. And therefore, many authorities recommend new treatment strategies for how to deal successfully with problematic areas where the resistance rates are really high. And these new treatment strategies, as we know, are based on levofloxacin treatment or the regimens where is rifabutin used. But still, this is, I don't think, the way to go. It's a way to go in areas with high clarithromycin resistance rates. But many authors, when they talk about the H. pylori treatment in the area of increasing antibiotic resistance, they are convinced that treatment success of more than 95% per protocol is obtainable, and therefore should be expected from us, the clinicians. And of course, the golden rule for choice of treatment is only to use what works locally. That means, for example, in Slovakia, what works, we use that. And then hopefully we will exceed this 90% success rate. The second major factor that affects H. pylori eradication nowadays are the adverse effects, and also the mentioned complexity of the regimen, because these both can lead to the non-compliance of the treatment. And we know that the compliance with therapy has major implications, because it can influence treatment failure in the antibiotic-sensitive patients, and also it can have influence also on the development of antibiotic resistance. And truly, this is a multifactorial process and gives challenges both for us, the physicians, and also for the patients. So what can we do as physicians in order to improve the compliance? First of all, we have to clearly understand the pathogenesis, sequelae, and the complications of H. pylori infections. And we have to be motivated to test for and treat the infection whenever it's appropriate. On the other side, we really need to provide to the patient true information which will lead to his empowerment, that the patient can play truly an active role in their treatment by complying with therapy. I think this is also the way to go. And most of us do not have any time or not so many time to speak with the patients, to empower the patient. And we have seen multiple antibiotic schemes, and these are used against H. pylori infection, as was mentioned, but they carry always the potential of GI side effects. And the poor treatment tolerability this is a cause of concern of us, because this may lead to treatment interruption. Therefore, as I have told you, the second most frequent cause for anti-H. pylori treatment failure in clinical practice is the non-compliance. And in order, from what we heard, we have to build a strategy that is targeted to improve treatment tolerability, that might improve the compliance and eventually also increase the eradication rate. And what do we have for tools? And we know from the studies, and we got data nowadays, that the probiotics is perhaps therapy with probiotics is perhaps the way to go. Because probiotic, as we know, is a living microbial species that upon administration may positively affect bowel microecology and also improve health conditions. And all the data that we got now that are available have shown us that probiotics are efficacious against antibiotic-associated diarrhea. And that's also the most common side effect of anti-H. pylori treatment. So the rationale for their efficacy is mostly based on restoration of normal flora colonization. And this can be seen firstly in the late 90s published papers that have been focused mainly on the experimental data, treatment of H. pylori with probiotics and so on. And due to the years, data were more recent, and they have shown us that supplementation with probiotics could be the way to go, because they could be effective in increasing eradication rates due to anti-H. pylori therapy. Also, these meta-analyses have shown us that when we compared the rates with eradication therapy alone and eradication therapy with probiotics, with the combined treatment, the eradication rate was increased. And the adverse effects, such as diarrhea decreased. And still, upon the knowledge that we have to confess that the mechanisms by which probiotics decrease H. pylori related gastric mucosal injury, it still has not been fully elucidated. And the treatments with probiotic most likely lead to a decrease of adverse events, especially decrease of diarrhea. Indirectly, or by decreasing these adverse events, they may help to improve the eradication rate. And this is why the statement 12 was also made in the latest consensus report from Maastricht 4, where the authorities stated that certain probiotics and prebiotics show really promising results as an adjuvant treatment in reducing side effects. But on the other hand, we have also to confess that, however, the poor quality of many trials and the limited number of centers involved should be emphasized, and therefore to preclude us to giving a positive recommendation. And all the meta-analyses that were done on studies where lactobacilli were used are heterogeneous because they mix different species, different strains. So therefore, truly, a lot of work, a lot of additional work needs to be performed to determine the strain, the dose, and also the administration to be used. So, ladies and gentlemen, let me conclude that we, clinicians, really need to be careful in way to consider the currently available options that we have for treatment of H. pylori. The current first-line treatment regimens, we know that they are effective, we know that they are safe, but over the past decade, they declined, they decreased in their efficacy. And mainly, this was an effect due to increasing antibiotic resistance. Alternative treatments with superior effectiveness should be sought and appropriately tested in a variety of populations. And novel therapeutic strategies have provided really promising results, and new developments are still ongoing. And I truly think that the treatment with probiotics are most likely to lead to a decrease of adverse event, and especially, as I mentioned, diarrhea, and therefore they may indirectly help in terms of improvement of eradication rates. But of course, more studies need to be performed. So coming to the end of my lecture, at the beginning I asked the question whether there is still a need for a new strategy in H. pylori eradication, and due to my knowledge and due to what I think is yes, there is still a need for a new treatment strategy. Thank you.